Assalamu alaikum. I'm Professor Dr. Hayder Mubarak. This is a practical session on the topic posterior triangle of the neck. As we said in the presentation of planes of the neck, that the side of the neck is considered to be quadrilateral region, as this dotted rectangle shows. This quadrilateral side of the neck is divided by the sternocleidomastoid into an anterior triangle and posterior triangle. The posterior triangle is the topic of this session. The most important and the first to start about description of the posterior triangle is boundaries of the posterior triangle. The posterior triangle has an apex superiorly and a base inferiorly. The base is the middle third of the clavicle between the attachment of sternomastoid anteriorly and trapezius posteriorly, while the apex is above at the superior nuchal line. The boundaries of the posterior triangle is formed anteriorly by the posterior border of sternocleidomastoid, posteriorly by the anterior border of a trapezius, and of course the base is the middle third of the clavicle. The floor of this triangle is formed by the prevertebral muscles covered by prevertebral fascia. The prevertebral muscles forming the floor of the posterior triangle deep to the prevertebral fascia are the following from above downward. First, semispinalis capitis, which is at the apex of the triangle, and this muscle is directed, the muscle fiber of it directed vertically, which is different from the direction of other muscles forming the floor, which are oblique. The semispinalis capitis muscle is inconstant finding. It is not always considered in the text as a muscle forming the floor at the apex of the posterior triangle. Below the semispinalis capitis is a long band of muscle which is called splenius capitis, and below splenius capitis is levator scapulae, and below levator scapulae is the scalene muscles, which are namely scalenus medius and scalenus anterior. And sometimes some textbooks consider that the first rib and first digitation of serratus anterior are also parts of the floor of the posterior triangle, but your theory is not considering that. So the floor is formed by the prevertebral muscle covering the following prevertebral fascia covering the following prevertebral muscles from above downward: semispinalis capitis, splenius capitis, levator scapulae, scalenus medius, and scalenus anterior. The roof of the posterior triangle is formed by the skin, as you can see also here. This is a diagram which had been described to you in the last session. Deep to the skin is the superficial fascia, and deep to the superficial fascia is the investing layer of deep cervical fascia that encloses sternomastoid anteriorly and the trapezius posteriorly. So this gap between sternomastoid anteriorly and trapezius posteriorly is filled by the roof, which is formed by investing layer of deep cervical fascia. So the roof is formed by skin, superficial fascia, and investing deep cervical fascia. And when you will say the investing the superficial fascia, you will have to say that the superficial fascia with its content, because the superficial fascia, as we will see soon, contains some cutaneous nerves, which are branches from the cervical plexus supplying the side of the neck, and also the superficial fascia contains external jugular vein. Regarding the contents of the posterior triangle, the apex of the posterior triangle shows the occipital artery and even sometimes the great occipital nerve, but both these are inconstant finding. They may not be described in some textbook. Also, the apex contains a lymph node which is called occipital lymph node. Another lymph node is above the clavicle, which is called supraclavicular lymph node. Other contents of the posterior triangle is the axillary nerve, the accessory nerve. The accessory nerve projects from the posterior border of sternomastoid at the junction of its upper and middle third, run downward and backward on levator scapulae to disappear deep to anterior border of trapezius at the junction of its lower one-third and middle one-third. And actually, the accessory nerve is a key structure in the posterior triangle of the nerve. First, because this key structure, the accessory nerve, indicates the muscle deep to it, which is levator scapulae. Second, surgeons consider that the region below the accessory nerve is a careful area because you have many vessels and nerves below it, while the region above the accessory nerve is a carefree area. Therefore, if you have an operation, for example, removing a lymph node or an incision, any type of surgery done above the level of the accessory nerve, you can work here freely above the accessory nerve because this is a carefree area. You don't have any important structure here. But if you have an operation below the level of the accessory nerve, this is a careful area. You may injure many of the nerves and vessels, and so the accessory nerve is a key structure in anatomy and clinical application of the posterior triangle of the neck. In addition to the great occipital nerve, the occipital artery, the occipital lymph node, and the supraclavicular lymph node, accessory nerve, as I said before, while the superficial fascia contain 4 cutaneous nerves supply the side of the neck, which are branches of the cervical plexus. These nerves are content of the superficial fascia, and therefore they may be considered as content of the roof of the posterior triangle. But the proximal parts of them in the posterior triangle are also considered as part of content of the posterior triangle before perforating the investing fascia and then running in the superficial fascia. Their proximal parts are considered as content of the posterior triangle. These 4 cutaneous nerves of the side of the neck, which are branches of the cervical plexus, which are content of the posterior triangle and content of the roof of the posterior triangle, include the following. First, the lesser occipital nerve directed upward toward the occipital region, and then the great auricular nerve, which is running upward toward the auricle, the transverse cervical nerve, or called anterior cutaneous nerve, and running forward to the front of the skin of the neck, and the supraclavicular nerve, which is running downwards, supplying the skin above the clavicle, supraclavicular nerve. All these 4 cutaneous nerves are branches of the cervical plexus. They project from the middle of posterior border of sternomastoid muscle. Other contents of course, these 4 nerves are marked here by the stars. Other contents of the posterior triangle are branches from the subclavian artery, which are transverse cervical artery, which is here called as superficial cervical artery, and suprascapular artery, which is below the transverse cervical artery. Both these branches are branches from the thoracocervical trunk of subclavian artery. The subclavian artery and vein are also content of the posterior triangle, in addition to the lower trunk or trunks of brachial plexus. All the trunks of brachial plexus are contents of the posterior triangle of the neck. You know, the brachial plexus is formed of roots near the intervertebral foramina, trunks, which is in the posterior triangle. Then the trunks divide. Divisions of the trunk are behind the clavicle, and the divisions unite to form cores in the axilla. The cores are in the axilla. The divisions of the trunks are behind the clavicle. The trunks are in the posterior triangle. So the trunks of brachial plexus are another content of posterior triangle. The trunks running between scalenus anteriorly and scalenus medius posteriorly, together with the subclavian artery. The subclavian artery is also related as the brachial plexus anteriorly to the scalenus anterior and posterior to scalenus medius. The phrenic nerve could not be demonstrated here. It runs anterior to scalenus anterior, running upward from the neck to the thorax, and is also considered as the content at the anterior inferior angle of the posterior triangle. The occipital lymph nodes have an important clinical application that it may be large in some infection, just like German measles, the rubella. These are the most important contents of the posterior triangle and boundaries of the posterior triangle. As I said, the subclavian artery is also, and subclavian vein are also contents of the posterior triangle. The subclavian artery and the brachial plexus run between scalenus anteriorly and the scalenus medius posteriorly, while the subclavian vein run anterior to scalenus anterior. Sometimes the anatomists divide the posterior triangle of the neck into two regions by this muscle. This muscle is called inferior belly of omohyoid. This inferior belly of omohyoid divides the posterior triangle into a smaller triangle below it, which is called supraclavicular triangle, and big triangle above it, which is called occipital triangle. Of course, the triangle below omohyoid, below the inferior belly of omohyoid, which is the supraclavicular triangle, sometimes is called also subclavian triangle because it contains the subclavian vessels. And in cases of bleeding, for example, deep wound in the upper limb, you may press here in this region above the middle of the clavicle, and then you are pressing in the supraclavicular triangle below omohyoid on the subclavian artery to minimize bleeding from a deep wound in the upper limb. Other applications in regard to posterior triangle are in consideration to the accessory nerve. Of course, this nerve, which is the accessory nerve that we had just described, is the spinal part of accessory nerve. You know, it is even written here, spinal part of accessory nerve. You know, the accessory nerve is the 11th cranial nerve. It is originating from the medulla oblongata, but the cranial accessory nerve, which is the original cranial nerve, receives contribution from the upper 4 cervical segments of the spinal cord, and here rootlets from the upper 4 cervical segments of the spinal cord ascend up to enter the foramen magnum, connected with the cranial accessory to form a mixed nerve, which is cranial and spinal accessory nerve. Then this accessory nerve will be exit out of the skull and then redivide. The cranial combines with the vagus nerve, and the spinal is here supplying sternomastoid muscle and perforating it, exit running on levator scapulae in the posterior triangle, and then pass deep to trapezius to supply it. So it supplies sternomastoid and trapezius. So injury to the accessory nerve in this region, to the spinal accessory nerve, will result in damage to this nerve and absence of function of trapezius muscle. We said sternomastoid and the trapezius, both of them are supplied by the spinal accessory. But if the accessory nerve is injured here by wound, the trapezius will be paralyzed. So when you told the patient to elevate his shoulders, which is called the shrugging of the shoulder, he will be able only to elevate the normal side, because the paralyzed side where the injury is to the accessory, to the spinal accessory nerve, shows paralysis of levator scapulae, and therefore the patient will not be able to shruggle his shoulder on the injured side. Another clinical important application in the posterior triangle. We said when we describe the roof of the posterior triangle, we can say skin, deep to the skin is superficial fascia, and then investing deep cervical fascia, which is surrounding sternomastoid anterior and trapezius posteriorly. So, and when we say the roof is formed by superficial fascia, skin superficial fascia, and investing deep fascia, we have to say superficial fascia forming the roof of posterior triangle with its content. The contents are these 4 cutaneous nerves, the lesser occipital, great auricular, transverse cervical, or called anterior cutaneous, and supraclavicular. I had just described these 4 nerves as a content of the posterior triangle and content on the roof of the posterior triangle, which is the superficial fascia part of the roof. Also the roof, the superficial fascia, contain the external jugular vein that we will discuss soon. Here there is another important clinical application. If someone is standing and have a wound in the external jugular vein, by gravity the blood will fall down and the air will be sucked inside the external jugular vein, This air will enter via the external jugular vein to the subclavian vein, to the superior vena cava, to the right atrium. And a large amount of air entering via a wound when the patient is standing in the external jugular vein. You know, this is a superficial vein. It could be injured easily in accidents. If a large air enters into the right atrium via this pathway, external jugular vein, subclavian vein, superior vena cava, and right atrium, there will be what's called air embolism into the heart, and this air embolism will lead to fatal results. It will kill the patient because the heart will not be able to pump blood anymore because of this air embolism. These are most points in regard to posterior triangle of the neck. Thank you very much.